Hi, everyone. This is Paula Smith, the President-elect for the Respiratory Therapy Society of Ontario. I want to wish everyone a happy RT week. A few things I want to let you know as participants, unfortunately, we can't hear your lovely voices, but please enter in comments into the chat. If you have any questions as we go along the presentation, I'll address them with us as a group. I just wanted to, just review the mission, obviously, of the RTSO is to promote and advance Ontario respiratory therapists and create opportunities for us for growth and advocacy and research. And we certainly have a vision to inspire RT excellence. And man, do we have a great Ontario RT crew in this province. I'm super thankful, and we're thankful for all of your contributions. Again, it's a time for us to band together and really showcase what we contribute. It's something that we don't do very well, I think, and it's something that we can certainly do more of now. COVID-19 has shone a light on us as respiratory therapists and the amazing value that we bring to the healthcare system. So don't forget to shout it loud and proud, and we look forward to seeing your pictures for RT Week celebrating. Don't forget to hashtag RTSO, RT Week 2020. We're happy to see you in your t-shirts and doing all of your cool, fun stuff as RTs. Of course, for those who haven't renewed your membership, I just wanted to put it out there that we have reduced our practicing membership to reflect the half year that's left. So it's $80 plus HST. I know I've received some feedback from some RTs that are so grateful about the pandemic pay that they vowed to take some of those funds to support us. Supporting us is actually really awesome because right now we're doing some really amazing things to progress as respiratory therapists in Ontario, and it's a great time to become part of those amazing changes. So today, I just wanted to introduce Madonna. She's going to be speaking to us about the management of asthma from mild to severe and how it's changed and what you need to know. It's funny how we RTs travel in groups, and we're a smaller profession, but we certainly tend to know one another. I've crossed paths with Madonna definitely over the last 20 years that I've been a respiratory therapist, and she always inspires me. She's always up to really cool stuff that's just promoting our career and just making care better for patients. So Madonna is the coordinator of the Asthma Research Group, Incorporated Best Care, and she's got an interest in chronic disease management, research and evaluation initiatives, and health system transformation. She's been an integral part of healthcare transformation and all of the above. She's got 30 years of experience as an RT, and she's been a certified respiratory educator since 2006. I'm really looking forward to Madonna to what you have to offer us today, and thank you very much for your time. Again, happy RT Week. I'm just going to put myself on mute, and I'm going to bring up the presentation.
Hi, thank you, Paula, and hi, everybody. And I just want to thank all those RTs that are on the front line in the hospital. I haven't been there in a while, so thank you to all of you that are putting yourself at risk every day. So I'm excited to share with you guys some of the latest information and updates in the GINA guidelines and the newest stuff about asthma. And of course, I can't go without just saying something about best care and what we're doing. So you might hear me talk a little bit about best care throughout, but I have 2 slides at the end. I just want to share with what we're doing, a whole bunch of your fellow colleagues out there in primary care. So let's talk about the management of asthma from mild to severe and how much it has changed. It's kind of cool to see because we haven't had a lot of changes in the guidelines for asthma in such a long time. So these are new times, and let's talk a little bit about it. So Paula is going to advance the slides for us. So next slide, Paula. So by the end of today, I'm hoping to shed some light on SABA reliance or overuse. So that's for just to remind everyone, I will use short-acting beta agonists. I'll call it SABA, and ICS will be our inhaled corticosteroids. I just want to bring an understanding about the new GINA guidelines and mostly the mild component of it. Understanding the choice of the reliever impact on patient outcomes in asthma, and understanding the difference between uncontrolled asthma and severe, which I think is really important for us to understand. and of course, what is the best care program and who we are. I'd love to share that with you. Next slide. So let's just talk about inflammation and asthma. So asthma, a lot of patients, we can't forget that asthma is a severe disease. It's a chronic disease. There's over 176 million asthma attacks that happen globally every year. But what I find people forget is asthma is actually a chronic disease, and it's all about inflammation. And it's so interesting that we treat it so much with a SABA, but it's really an inflammatory disease. The other thing to remember is we're lucky enough to have an anti-inflammatory / reliever at our fingertips, and that GINA has updated the new guidelines. So next slide. There we go. So knowing that it is a burden across the world, let's just look at the amount of patients that have asthma. So 339 million people have asthma. But just in Canada alone, we have 3.8 million, over 3.8 million. And in 2000, it's showing the 2015 stats here of approximately 250 deaths per year and over 70,000 ER visits. Those numbers haven't changed year to year, and to me, somebody dying of asthma is a huge problem. So those are just astounding stats. Let's go to the next slide and let's talk about the paradox of asthma. So I've said this before, but if you think about asthma, it's a chronic inflammation disease. So why do we treat it with the blue puffer? Everybody, you see pictures of asthma, we got the blue puffer, and everybody thinks of Ventolin as our reliever, and that's how we treat asthma. Really funny that we're doing that, but yet it's a chronic inflammatory disease, not the way we should be treating it. We use SABA alone to control it. And why aren't we minimizing that and starting to think about ICS as our regular treatment? The other thing we need to think about as a paradox is that that the safety messages are not very clear. If for some of you that have been out there for a while, if you think about LABAs, we all know you can never give a LABA to a patient alone with asthma. It has shown increased death rates with that, but yet we're giving them SABAs, which kind of work the same way, just short acting. So there's a lot of conflicting messages in the literature and in the guidelines, not so much the literature on that. And the other thing is the disconnect of the patient understanding their asthma control and their symptoms. They are poor perceivers in many cases, and they just think it's okay to cough every day, and that's okay because I have asthma and I just cough. So we want to change that for people. So let's look at, next slide, let's look at patients with mild asthma. So these are the ones that aren't using, or at least we find as an educator out there, that have probably the most mild or exacerbations. And all these studies show that for us. They show to us that mild asthmatics actually exacerbate. And there's a lot of work done here and a lot of work done by our Canadian colleagues, Dr. O'Byrne, which is really exciting. But it shows 19 to 36%, if you look at all these studies, that mild asthmatics exacerbate. So we have this thought that only the severe patients exacerbate, which is actually untrue. And the worst part is, of all the population, that the mild asthmatics account for 50 to 75% of all asthma. So that's something we need to think about, is that asthmatics, a lot of our asthmatics actually are mild. So let's go to the next page, or the next slide. This slide, to me, I just feel we could stop at this slide, but it has the biggest impact for me as an educator and as a respiratory therapist. If you look on the left side, and let's look at the canisters of SABA, and as they go up and the more canisters you use per month, the increased rate of death. And that has been shown over and over. So again, we're telling people it's okay to use SABAs, but they're dying more from using that. And if you think about it, they've shown 74% of patients prescribed an inhaled corticosteroid still use SABA every day. And our guidelines are very clear. If they're using SABA for exercise, that counts as not being controlled if they're using that every day. So for any of you, if you're using a SABA daily and your patients are on ICS, that is still not considered controlled asthma. And 74% of our asthma patients do this. If we look on the right side of the slide and we look at the amount of canisters per year of ICS compared to asthma deaths, the least amount of canisters or the lower amount of canisters used, the death rate increases significantly. So again, not treating the underlying inflammatory process is a big problem and relates to increased asthma death. The other thing is, if you look at patients that have been in the hospital and have been discharged, there's only a 50% adherence to the ICS 1 week after hospital discharge. So this goes to a lot of my point with patients where they're feeling better and they stop using it. So next slide, please. Let's look at patient's perspective. So up to this point, I've showed you the literature and what we see, but let's look at the patients and how they feel. So this was part of the INSPIRE study, and there were 11 countries involved in this, and we're looking at almost 3,500 patients and their attitudes about asthma management. And 39% of the patients believe there is no need to take their medication every day, especially if they're feeling well. So again, they're not understanding the underlying reason for it, and they're not understanding that it's a chronic disease. 90% of them want the treatment that provides them immediate relief, and that through and through would be their blue puffer or their SABA. So they take it, and as you all know as RTs, we give it to them, and they feel relief within a few minutes. So they feel that that is working for them, and that's what gives them the relief. So just kind of the take-home message on this component is patients with asthma feel that they forget that it's a chronic disease, they don't understand it's a chronic disease, and they really don't understand the importance of treating it daily, and people die from asthma. So just keep that in mind as we go forward. So let's go and let's look at the next slide, and we're going to start talking about the Sabina study. So the Sabina study is the overuse of SABA. And this is a hallmark study that was used to evaluate the burden of SABA use and its relationship to ICS maintenance therapy. What's really cool is if you look, we were part of this in the SABA-2 trial, but this study was a retrospective observational study. So we need to keep that in mind. It's the largest in the world, and this is what is making us think differently about how we treat asthmatics. I kind of want to be clear. Some of this information, I think as educators and as RTs, we know, but now we have the studies to show it. So what did they do? They evaluated the prescriptions, the exacerbations, and the healthcare utilization related to SABA use in asthma. So let's look at what the study showed. So if you could go to the next one. So just to remind everyone, the closer these bars are to 1, show that there's no relationship, and the further they are away, there is a relationship. So when we look at somebody that was on 3 or more canisters per year, there was a greater relationship associated with exacerbations. Now, this is in GINA, step 1 to 5. So this is from the very mild to the very severe patients. And what did it show? If we look at the top, the UK and any of the Canadian sites, Netherlands, it shows a very strong relationship that the more SABA they use, the more it's associated with exacerbations. Poland is way out there, so very, very big relationship. If we look at US, there still is a relationship. It's a little less, but there still is a relationship showing that if they used more SABA, 3 or more canisters, that there is an association with exacerbations. So if there is a little bit of an explanation as to why the US might be a little closer to the 1, and that some of that is because most of the population in this part where they were looking at this cohort, they had a lot of patients that were in step 1. So that's very, very mild. But even though that's true, there still is a relationship associated with exacerbations and use of SABA 3 canisters or more. So let's go to the next slide. And this digs a little bit deeper with our sicker asthmatics, or our asthmatics that are more moderate to severe. And if you look at this slide, it now shows the step 3 to step 5. And as you can see, everybody's off the 1 line, which is showing a very clear association that the more SABA they use, the more exacerbations are associated with that. So the Sabina study really identified the overuse of SABA and really clearly showing we need to think about ICS and treating the underlying inflammation. So that's just the research and the data component of the SABA trial, which was very important to have been done so that we can see how asthma should be treated moving forward. So let's move on to start thinking about the GINA. So GINA guidelines, they're guidelines that we use in our everyday practice. We follow these guidelines for all of our asthma patients. So I know there's probably a mix on the line of RTs that are in primary care, home care, hospital, home and community care. But I think at the end of the day, this relates to all of us. So let's go to the next slide. And I just want to show you, this is the GINA in 2018. And there's only one point I want to show to you. If you look at step 1, the treatment of choice was a SABA. So you could consider other, but the treatment was to put patients in step 1 just on a PRN reliever. So that's changed. So let's go to the next slide and let's talk about what the changes are. So in 2019, this is a fundamental change that has happened in asthma management. And I'll be honest, I haven't seen this change in a very, very, very long time. GINA no longer recommends treating adults and adolescents with asthma with short-acting bronchodilators alone. So thinking and remembering that it is an inflammatory process. So this is really exciting for us. So let's go to the next slide. I'm not going to read through all of these points, but I just want to really identify the points for all of you guys, or all of you on this, that let's just think about the background and the risks of mild asthma. So patients with mild asthma, we know are at risk for serious adverse events. So we've talked about that in the beginning. We know people die from it. We know that they have near fatal asthma events. You know, in the hospital, we treat these patients and we need to think about that. The other thing when we think about risk of mild asthma is mild asthmatics have those exacerbations, but these are triggered by many things. A lot of it is triggered by viruses, pollens, pollutions. There's all kinds of triggers for our patients. But more importantly, not only the triggers, we have to think about the poor adherence to medication. So back to they take it when they feel they need it. The inhaled SABA has been the first line treatment for asthma for over 50 years. So now I'm going to date myself. I was in RT school, started in 1989, and I will never forget when I was just leaving RT school, they were just really pushing that we must treat asthma with inhaled corticosteroids. And when I first went into school, you heard a lot about Ventolin, Ventolin, Ventolin. So even back then, they were just making the shift over to inhaled corticosteroids and really trying to push that with the patients and with the treatment. The other thing is patients commonly believe my reliever gives me control over my asthma. So they feel that benefit, they feel that's working, and think about if you're in pain. If you're in pain, you have to treat it. So we treat anything that's in pain. But with asthma, we don't seem to treat it as regular, or we go to something like a reliever that gives you benefit right off the bat. Next slide. So if we go to the background or continue with the background and the risks of SABA only treatment, this was very interesting to me to learn about this, and I learned about this more as an educator. But when you overuse SABA, you actually are creating issues in your airways for overusing it. So your beta receptors have a down regulation when you overuse it. You start to decrease your bronchoprotection. You get rebound hyperresponsiveness, and you have a decreased bronchodilator response. So actually that's very worrisome to me when we start to treat our asthmatics. There's also an increased allergic response and increased eosinophilic airway inflammation with this. So that's a very interesting kind of knowledge for me to think about. And I actually tell my patients about this if they're using a lot of SABA over and over and over. The other thing is higher use of SABA is associated with adverse clinical outcomes. So we've talked about that. The more canisters we use of it, the higher risk of exacerbation, higher risk of hospital, and higher risk of emergency department use. So let's take a step back or move forward and think about, next slide, sorry, Paula, the 12-year history behind the changes in the GINA 2019. So GINA has actively been seeking interventions for mild asthma. So as I told you earlier, that is the majority of patients with asthma have mild asthma. They don't use their medications. So we want to start thinking about how to treat these patients better. How do we stop them from having exacerbations? They emphasize the poor adherence and the modifiable risk factors for exacerbations. We need to do something. We need to make a change in the way we do our care. I'm going to relate it a little bit. I'm going to take a chance and throw out COPD at you. In COPD, it's the #1 reason for hospitalizations and emerge use. But yet, we still keep treating the COPD in similar ways. We have to think differently about our health system and how do we change our health system to help patients with COPD and asthma. And how do we change our health system? That's something that we've been working really hard on with Best Care, is we need to get more resources out there in primary care for our physicians. And I think that's a huge role for us as respiratory therapists and educators to do. And part of our role is exactly this: help patients become more adherent, help them learn what they need to do, and help decrease their exacerbations. And the last part on this is we now have some randomized controlled trials that identify what anecdotally we know has been happening. And to me, this is exciting because now we actually have the guidelines, or not only the guidelines, we have the studies to prove it. And that's where the Sigma study came in. We'll go to the next slide. So the last piece on the GINA is the landmark changes in asthma management. So what are they telling us? No longer recommending SABA only treatment for step 1. Makes sense to me. They recommend that they should all receive an ICS containing controller treatment. I'm going to show you this in a little bit more detail, and it can be as needed. And the other component that I think is really cool that GINA is doing, and I think we need to do this, is we need to start thinking from a population risk reduction strategy. We see a lot of that. The examples here are statins, antihypertensives. We got lots of population risk reduction for smoking cessation or for smokers. So we need to think about a risk reduction strategy. If we don't think that way, then we're doing a disservice to all of our patients. We'll go to the next slide. So these are the GINA guidelines. So you know what, we could debate if we should follow these guidelines or not follow these guidelines. Best Care and me as a researcher slash educator slash RT, I really believe in the science. And I also look to the experts. And that's what the Global Initiative for Asthma is all about. They're the experts. If there's not evidence, there's a table of experts that go over the research and their expert opinion. And we have 2 leading Canadian asthma specialists, respiratory specialists on this committee or the GINA guidelines. So I look to them as leaders. I just want for any of you that don't know how this guideline, what this all means, I'm just going to set up the landscape for you. So in asthma, it's all about, first of all, we need to confirm the diagnosis. That's super, super important. And if we don't do that, then we have problems because maybe it's not asthma. And for anybody who knows Sean Aaron's research up in Ottawa, he showed that 30% of people were actually misdiagnosed with asthma. That's a huge amount of people. And I think it's really important for us to make sure we confirm the diagnosis. The other thing we need to consider is their symptom control, their environmental factors, all of their comorbidities, and adherence to medication and inhaler technique. So I'm talking about the circle part, just go up to the right of that. That is super important. But whenever we make any treatment change, we always need to first assess, then adjust, if we need to adjust for any non-pharmacological or medication, we need to adjust, but then we need to review the response. And that's the exciting part about what we do out in primary care is we do spirometry, a little less now with COVID, but we do it, and we're doing that right at the medical home with the patient. So we can actually assess their lung function, and we do that. Most of us are RTs and we do it very well. So let's look at what has changed in the guidelines. So if we look at on the left side, we have our preferred controllers and we have preferred relievers. So the box is highlighted to the biggest change. If you remember, that was not there in that slide I showed you previously. So what's exciting here is they're actually saying you need to use as needed low dose ICS for Formoterol. It's a combo medication. It gives them the fast reacting that they need, but it also treats the underlying disease, which is our inflammatory process with ICS. But there are other controller options that we can use. So I just want to be clear. The other option is they can take their SABA, but every time they take their SABA, they need to take their ICS puffer too. So they'll take 2 puffers is the other controller option. So the first option is the one puffer that has the low dose ICS and formoterol as needed. And then the second option is they can use the SABA, but every time they use their SABA, they need to grab their ICS puffer at the same time. So that's what one of the biggest changes are. And I'm excited about this because knowing that asthmatics do not use their puffers as regular as they should, at least when they're grabbing the puffer, they're going to have some ICS in that puff that they take. And if you just go to the next, slide, Paula, it's just going to show you the step 2 part. And the step 2 piece of it just shows that they have also allowed the as needed there, but also the daily low dose ICS, which is super important that patients, that is an option, knowing that it is chronic. So the major changes have been for step 1 and step 2. And these are your mild asthmatics. But if you look at step 3, step 4, step 5, our ICS is core now all the way across from step 1, step 2, step 3. Let's go to the next slide. I just want to show you, because some of you might be saying, well, oh, go up one, Paula. Go up one. Oh, you know what? Paula, I think you have the one where I hit it. Okay, so go just back up to that.
Okay,
sorry.
No, that's okay.
Just go
Teamwork.
back to the GINA. Yeah.
Sorry about that.
We do that well as RTs.
Is that okay there?
Right. Yeah, we'll just stay there. So I'll just identify what is step 1 when we think about symptoms. What the patients we're thinking about in step 1 are symptoms or patients that have symptoms less than twice a month. And as you go to step 2, we're starting to think of symptoms twice a month or more, but not daily. And then as we walk up, step 3, they have symptoms most days. They are waking up at night with their symptoms, and then it continues up the ladder from there. So I just wanted to identify the type of patients we're looking at for step 1 and step 2. The other thing, my last 2 pieces on the GINA and the guideline piece is when we think about symptoms, I just really, really encourage all of you to think about when patients say, I don't have symptoms, dig a little more. If you start to really talk to them a lot more, you will find out they probably have more symptoms than they even realize, because as patients, you start to get a little bit used to it. And don't even realize you're having symptoms. Sometimes I actually even ask the caregiver or the mom or the dad or their partner, and they will say, oh my gosh, you cough every day. And the person will say, or the patient will say, I didn't even realize that. So they're really just kind of get used to the coughing or to the shortness of breath or waking up at night coughing. If they wake up at night and they're coughing, that's usually a pretty good sign that they have asthma. So lastly, just before we go off this slide, when I used to teach in the respiratory therapy school, anybody who had me as a prof, they would remember me saying, I used to say asthma, ICS, inflammatory. Asthma, ICS, 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 COPD, bronchodilate, bronchodilate, bronchodilate. So if you remember anything from anything I've said today, just remember that. Asthma, inflammation, ICS, COPD, bronchodilate, bronchodilate, bronchodilate. Let's go to the next slide. And let's look at the evidence. So I keep telling you a lot of stuff. I'm just going to show you a few points on the evidence. So this is from the Sigma study. This was one of their secondary endpoints, I should say. So what this is really showing on the left side is the as needed terbutaline. So for any of you that aren't sure about that, that's equivalent to our salbutamol, Ventolin. It's Bricanel in other terminology. So that's the as needed SABA. If you compare it, and we're looking at the severe exacerbations, when they compared it to as needed budesonide and formoterol, there was a 64% reduction in exacerbation rates. That's huge. So that was one of the significant outputs that came from this study. If we go to the next slide, and to me this is really important, this slide, is what it showed was that the as needed budesonide formoterol, which is on your right hand, compared to being on a maintenance dose of budesonide. So we're talking they've been on ICS maintenance dose compared to as needed budesonide and formoterol. And it showed that it was not inferior. So that is really, really important information for us. And this was the Sigma 2 study, and this was their primary endpoint. Let's go to the next slide.
Madonna, would it be okay to ask you, there's a few questions just in regards to the GINA. Is this a good time?
Yeah, go ahead.
Okay, super. So Carolyn said that I've heard Dr. Chapman speak, who spoke about the GINA guidelines as guidelines only and to not replace current CTS guidelines, which recommends low dose ICS daily for mild asthmatics. After the GINA report came out, after the GINA report came out, this is my old 40-year-old eyes here. The number of providers prescribing Symbicort PRN only for asthma or suspected asthma increased, resulting in significant costs for the patient and the pharmacy because they couldn't provide an LU code. If there was, are you suggesting the GINA guidelines be considered instead of CTS?
Okay, so there's a few things. We have new CTS asthma guidelines that are imminently coming out. And there was a paper from our CTS guideline writers for asthma that put a response out to the GINA, the new GINA guidelines. So I would suggest that that would be a good starting point of reading their response. They asked a lot of questions. I forget the girl's name the lady's name in Australia. She was the lead on this. And the CTS went and asked a whole bunch of questions with the responses from her, and that was published. So that's really important to review maybe and to look at. The second piece is we are getting new guidelines out, and you will know as well as I will know. I suspect they may reflect what I'm talking about today. The other thing, so as we all know, there's the respirology world, and I'm not speaking for Dr. Chapman or any of the respirologists, but the way we look at it is guidelines are a guide for us, and that's the best we can do. But I'm going to tell you my own bias. What I like about the GINA in it is I totally agree that if a patient has asthma, they should be on ICS daily. I totally agree with that. But let's remember that those guidelines prior just said Ventolin. So I disagree with that. The second part that I like about these guidelines is in my practice, and anybody who's an educator out there, I think they would concur with me, is the mild asthmatics don't use puffers at all. They come on and off depending on how they're feeling. I just think that this is a really good option for those patients that will not take an ICS regular. And when they go to grab, they either grab their budesonide and formoterol, which is the only one that has been approved for this, or they grab their SABA and they grab the ICS together and do that together. So I think it's good advice for patients that we know are not using their puffers at all. It's better than nothing.
I see. And if ICS is used PRN once or twice weekly, asked Carolyn Savage, would it really have any impact if the onset of action is slow?
Sorry, I missed the first part of it, Paula.
So if the patient is only taking it once or twice a week, will it really, use PRN once or twice a week? Would it really have any impact if the onset of action is really slow?
Yeah, so that's what they're showing here, is that it does have impact, and patients are having less exacerbation. If we go to the next slide, this might also help with answering that question, and then we'll continue on with the questions. If you can go to the next slide, I think this might help a little bit on that answer.
Is that the one?
No, one more. Oh, go up. Go back one, sorry.
It's okay, there's a delay too.
I think so. Go down again. Oh, right,
So,
that one, the comparable.
Okay.
That's what I'd like. So this is the sigma 1 and 2, and this again is our mild stage 1 and 2. And if we look, what they're comparing is patients that are on regular, in the sigma 1, patients that are on regular budesonide twice a day had compared to budesonide and formoterol as needed, it is showing that they still have a decrease in severe exacerbations with an 83% reduction of the amount of steroid that they used. And then the sigma 2 had similar results with a 75% reduction. So again, my bias, I will be very honest, I suggest ICS for all of my patients, but we're talking about the mild patients that are just at this point, prior to this, we're grabbing a Ventolin or grabbing their SABA. So what all we're saying is, don't just grab your SABA, grab your budesonide formoterol, or if you're going to grab your SABA, grab it and add an ICS. Take a puff of your ICS. So I think this is really compelling evidence that of why GINA changed their guidelines. There is so much more, and I'm not a respirologist, so I'm not going to pretend that I could talk right down to the lower levels of this. But from an educator perspective, I think this is really, really appealing, especially for our patients that aren't using their puffers. Any other questions? Thanks, Caroline.
Are we only smart dosing 8 puffs per day, or has the guidelines changed?
Yeah, so smart therapy is a great therapy, and yes, you can use that, but that's just an option. Just to remind everyone, there's a lot of different options out there. Smart therapy up to 8 puffs a day is one option.
Sarah Hannah, oh, sorry, go ahead.
I was just going to say we could spend a whole day just talking about all the options and as you walk up the steps on the guidelines.
Right. So it's not regular use of ICS, but as needed, asked Sarah Han.
So in the step 1, it's as needed ICS, but you have to use your SABA with it. So it's your SABA. And do you want to go back to that slide? So maybe we could just clarify this for everybody. Thanks for the question, Sarah.
No problem here. Let me get you back to this. I think I know where you want to go. Right here.
Nope. Keep going. The GINA one. Right there. So if you look, the preferred controller is as needed low dose ICS formoterol, but then the other option is it's still PRN ICS, but you use your SABA with it. Good. Any other questions? So I think the take.
Sorry, so Symbicort PRN can be used examply twice a week only.
As an example, twice a week, did you say?
As an example. So Symbicort PRN can be used, for example, twice a week only.
Right. So yes, if they are mild and that is controlling their symptoms. If they use that and they continually have symptoms every day, absolutely not. You have to step them up in their treatment until they're not having symptoms. And in the GINA guidelines and in our Canadian CTS guidelines, it shows about what the symptoms should be. Coughing 4 times or less a week, there are guidelines for us as to what the symptom management is. So we're just talking about the mild asthmatics that have very few symptoms. And if you remember, it was only 2 times per month that we're looking at for these patients. So I just don't want to give you the impression that I'm talking about the whole asthma piece. We're just talking about the very mild step 1. If they continue to have symptoms, you have to step up their therapy.
Thank you for that answer. That's awesome. There's a question. The presentation will be made available on our YouTube channel after the fact. Ellen. The other thing was asked, so what is the max dose for a PRN ICS with formoterol?
It's the 8 puffs per day. 200 micrograms, 8 puffs per day.
Super. Thank you. I think that's it for questions for now.
Okay, so let's keep rolling and let's.
Sounds good.
So I think our take-home message is we're just talking about the step 1, the very mild, and this is the option, and it's a good option from my perspective because most of these patients aren't even taking puffers. So let's go in, keep moving. This just showed the exacerbation rates. This was the last slide I wanted to show you on that. So let's move into more severe asthma. Let's go to the other end of the extreme. So you can keep going.
Sounds good. We have 12 minutes left, Madonna.
Yeah, so let's do the asthma, the severe side. So 8.4% of Canadians have asthma, but out of that, only approximately 5 to 10% have the severe asthma. So there is a difference between uncontrolled severe and uncontrolled asthma. But when we're thinking about severe asthma, we got to think about their uncontrolled despite use of puffers and long-term use of oral corticosteroids. We also have to think about corticosteroids have lots of side effects. And then I want you to think about the morbidity and the mortality we've talked about with asthma. We can go to the next slide. The next slide is just going to identify that so this is our colleagues in British Columbia that did this. And if you look at the left side of the slide, that is the percentage of asthma with severe. The 7%. If we look at the 7% out of all of these asthmatics, 7% of them were truly severe asthma. If we look at the right-hand side, though, those 7% account for 61% of the direct costs for asthma. So they use the most hospitalization, ER visits, and a lot of medication. So obviously it makes sense that they would be the high percentage of the direct cost. If you want to go to the next slide. The next slide is just a crazy busy slide to show you and remind you all. Oh, I think we have a little delay. There we go. Of all the issues that OCS or oral corticosteroids cause our body. So this is just to remind you that we don't want people on it long term if we don't have to. So we'll go on to the next slide. And let's look at the definitions when we're talking about uncontrolled versus severe asthma. So in order for you to be considered uncontrolled, we're looking at poor symptom control, according to our CTS, frequent exacerbations, serious exacerbations, so they've been in ICU, hopefully not mechanically ventilated, but that could happen, and they have airflow limitation. So that's something we think about for uncontrolled asthma. And if you want to go to the next slide, and this is defining uncontrolled severe asthma. So this really takes it a further step. Usually for us to consider them uncontrolled severe is we've already figured out they have adherence to their medication. That it's not that they're not taking their medication. So in order for us to consider it severe asthma, they require treatment. They have systemic corticosteroid use 50% of the previous year, and they're uncontrolled despite their therapy. So the next slide is really to me, the most important. In order to distinguish between it, we need to think, do they have a diagnosis? I told you earlier that a lot of the diagnosis is subjective. It's very low amounts of people that have had spirometry done to diagnose it. We have to think about adherence and inhaler technique. That is super, super important. And ruling out comorbidities, thinking about the mimickers like reflux, all the work Sean Aaron showed us with 30% of the patients not being or being diagnosed with asthma and not having asthma. We need to think about that. This is the part that Best Care and all of us educators do really well out in primary care. But if they step to step 4, that is what is really important and starts to put them towards the severe asthma side, and then they characterize their phenotypes. So let's go to the next slide. So adherence is super, super important. These are the CTS guidelines, and this, for any of you that know the asthma guidelines, this is just a very small piece of the bigger guidelines. So my point to this is a very small piece, but we're looking at they still need a good diagnosis. We need to think about environmental control, education, and an action plan. And now we're starting to think about assessing their phenotypes. So we're starting to think a little differently, and there's new medication or newer medications out there. Let's go to the next one, just to highlight the point about we get to this point when I'm talking about that part of the algorithm, we're starting to think about assessing their biomarkers, their phenotypes, and we're looking at their blood eosinophil levels, their total IgEs, their aeroallergen testing, their eosinophil counts, their nitric oxide breath tests. That's what we're looking at to assess their phenotypes. And at that point, what's exciting is we have all of these biologics now that are good, that we can start thinking about using for our patients. And if you just go to the next slide, these are the phenotype, or these are the biologics that we have. I'm not getting into any of this. When you get to this point, they should be seeing a specialist or an allergist, and that's what we tend to do. So let's just go to the next slide. Just shows us we have some exciting treatment options for us, and you can go to the next slide, Paula. Some exciting treatment options for us. So when do we send, just go up to the specialist one. When should we be sending these patients to a specialist? This is, go down one more. There we go. So we're trying to prevent this bottleneck, and this is really important. When we have diagnostic uncertainty, we need help. When the asthma severity is, and they're high-risk patients, and we have uncontrolled asthma, we need some help. Use of corticosteroids. If that's the only way we can treat them, we need some help. So we need our specialists to look at biologics. And first of all, do we have the right diagnosis here? Is it being treated right? Do we have them on optimal therapy? And if we do, let's start considering some biologics. So just one more slide on that. So this is what we're trying to do with Best Care, is we're trying to start to think about, let's stop that bottleneck to the specialist. Let's get the right people to the specialist. So these are the red flags. If they're on, for you to think about, the patients used 2 or more courses of systemic steroid in the last 12 months. They've been to emergency or unscheduled visits. They've been intubated or admitted to ICU, or they've used 3 or more SABA containers. We should be thinking about a specialist. So just thinking about being smarter about how to send them to a specialist. And if you just want to go to the next slide, I just want to finish up and just share a little bit about our best care. So we've been doing this since 2003. I'm just going to show you two things. This is my plug for us RTs out there. So best care is a plug and play program. We're out in primary care and we're really looking at the triad of the patient. We're case managers where we have the patient and the educator sit together. We case manage, we figure out what to do with that patient, and then we bring the GP, the provider, the NP, and we have a conversation and we take care of the patient and manage them right there in primary care. We've been doing this for heart failure, AFib, asthma, and COPD. But what is more exciting is I have a team of 30 people and 25 of our team are respiratory therapists and they're certified respiratory educators. And just one last slide that I'll close with. Just for any of you RTs that are thinking about becoming an educator, I encourage it because this is the kind of stuff that we do every visit with our patients. I'm not going to read it all off, but this is the type of work we're doing out there in primary care for asthma and for COPD. And I think RTs this is a great profession for us and a great, another part of our profession. We're not just all hospital-based, we're out there in primary care making a difference. We're certified respiratory educators, and we're actually case managers out there with all of our patients. So I will stop there and let you ask me any other questions that you'd like to.
I'm just looking for some questions. Anything that hasn't been addressed, we will post a question and answer sheet on the website. That's typically what it does, so it will show up. There is one question, and we only have 2 minutes. So how do you receive funding for primary care programs like yours?
Yeah, so great question.
Foster asking.
Yes, we are completely funded by the Ministry of Health and Long-Term Care. We've received some significant funding to spread out our COPD and heart failure program, but it's ministry funding. And we've been working real hard since 2003. We've been working on this. If you want any tips or you want to know more about it, maybe Paula, you could give out my contact and we'd love to talk with anybody and help you if I can help you with anything on getting funding in your area.
That's awesome. Thanks so much, Madonna. That was really, really good. I know I needed a brush up on these recommendations, these guidelines, and I'm excited to see how that pans out and emerge as we're practicing with our clients. But thanks for the tremendous value that you bring to our, our community, the people that we serve. You're a great representation of what we RTs can do, certainly together, to improve the lives of others. So thank you for your time today. Thank you, all the attendees, for spending time with us. We will post this broadcast on our YouTube channel for review later on. Thank you very much. Have a happy RT week. We'll talk to you soon.
Bye-bye.